I'm an addiction medicine physician in the community. My practice is based in downtown Toronto. However, I see patients throughout Ontario via telemedicine. Today's presentation is titled The Pharmacology of Opioid Agonist Treatment. I have no current or past relationships with commercial entities. I have received a speaker's fee from the Ontario Pharmacists Association. This complementary program is made available through funding from the Ministry of Health and Long-Term Care. So, like with any presentation, we're going to start off with our learning objectives. We're going to start off by discussing the pathophysiology and diagnosis of opioid use disorder. We're then going to explain the treatment modalities available for opioid use disorder. We're going to describe the pharmacology of buprenorphine naloxone and understand how to induce a patient on this medication. We're then going to describe the pharmacology of methadone, including adverse events and drug interactions. And throughout the presentation, we're going to be discussing the pharmacist's role as part of the addiction management team. I'm going to start off by reading a statement from the Methadone Task Force. It's specific to methadone, but can be applied to any form of opioid agonist treatment. Pharmacists are an important part of comprehensive methadone treatment. They have daily contact with clients and can develop a rapport with them. They can assess how they are managing their treatment and help the physician determine when the client is ready for take-home doses of methadone, also known as carries. Pharmacists can also play a key role in helping clients succeed with methadone treatment. Throughout the presentation, we will be following a patient named Alex. This is a very common scenario that I come across my addiction medicine clinics. Alex is a 30-year-old male who presents to an addiction medicine clinic seeking help for his opioid use. After sustaining a knee injury at age 25, he was prescribed oxycodone. He then became dependent on this medication and began to take more than prescribed. After multiple early refill requests, among other concerns, his family doctor stopped prescribing any opioids. Alex was not able to find another prescriber, so he started to purchase prescription opioids from the street. So let's start off with our first learning objective, discussing the pathophysiology and diagnosis of opioid use disorder. So this is an overview of the pathophysiology of opioid use disorder, but it can be applied to any addiction. Biological, psychological, and sociocultural factors all play a role in developing addiction. And of course, there has to be an addictive substance or behavior. And the neurotransmitter most likely involved in the development of addiction is dopamine. So all these factors here contribute to the development of addiction. So what is addiction? Addiction is a primary chronic neurobiological disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. It is characterized by behaviors that include one or more of the following: impaired control over drug use, compulsive use, continued use despite harm, and cravings. part of addiction involves developing a dependence to a substance. What this means is that if the individual either stops or reduces the amount of that substance, they will exhibit a classic and typical withdrawal syndrome that is specific to that substance. Another component of addiction is the development of tolerance to said substance. What this means is that more and more of a substance is required in order to obtain the same effects. So how do we formally diagnose addiction? There are a variety of diagnostic criteria, but the one used almost exclusively in Canada is the DSM-5 criteria. You can see here that to meet criteria for an opioid use disorder, or any substance use disorder for that matter, the individual must have at least 2 of the following 11 criteria. I'm going to go through them briefly. Criteria number 1 is opioids are often taken in larger amounts or over a longer period of time. 2 is that there's unsuccessful efforts to cut down. 3 is a great deal of time spent in activities necessary to obtain the substance, in this case opioid, or recover from its effects. 4 is a presence of cravings. 5 is recurrent opioid use resulting in a failure to fulfill major role obligations. 6 is continued opioid use despite having persistent or recurrent problems from the substance use. Seven is activities are given up due to the opioid use. 8 is recurrent opioid use in physically hazardous situations. 9 is continued use despite knowledge that it's causing harm. 10 is tolerance, which we just talked about. And 11 is withdrawal. You need to have a minimum of 2 of the above to meet criteria for an opioid use disorder. Mild means that the individual meets 2 or 3 of the criteria. Moderate is 4 to 5, and severe is 6 to 11. These 2 criteria here are starred because if an individual is prescribed an opioid and taking it as prescribed, they still will develop some element of tolerance and withdrawal. This is, and in this case, would not be considered a opioid use disorder. So if they have a prescribed opioid, then you cannot use these 2 criteria. But they can still have an opioid use disorder while prescribed opioids if they meet the other criteria. So now that we have an idea of how to diagnose opioid use disorder, let's move on to reviewing treatment options. Most addicts follow these stages on the road to recovery. Several will start at the pre-contemplative phase. What this means is that the substance user does not intend to take any action in the foreseeable future, and often are unaware that the substance use is problematic. Then some will move to the contemplative phase. These are users that are beginning to recognize that their substance use is problematic, and they're considering taking action. The determination phase, also known as a preparation, is when the user is ready to take action. The action phase is when the individual starts treatment, for example, an opioid agonist treatment. Then there's the maintenance phase, where the individual is stabilized. However, there can also be relapses, right? But also recovery. So what is opioid agonist therapy, also known as OAT? Essentially, they're medications that are prescribed for the treatment of opioid use disorder. They're used in conjunction with counseling, regular follow-up, preventative care, and referral as required. CRISM, also known as the Canadian Research Initiative in Substance Misuse, put out a national guideline for the clinical management of OUD in 2018. In it, they recommend opioid agonist treatment, with first line being buprenorphine naloxone, second line being methadone, and third line being slow-release oral morphine, or SROM. These are all considered forms of opioid agonist treatment, and opioid agonist treatment is first line for opioid use disorder. They do not recommend withdrawal management alone, with no plans to transition to OAT, and we will talk about that towards the end of the slide, the reasons why this can actually be dangerous. The guidelines generally do not recommend oral naltrexone, and they recommend that throughout the above, non-pharmacological management, including counseling, be used. Now, let's talk about the first line OAT, buprenorphine naloxone. Let's continue on with Alex. On further history, Alex shares that he developed tolerance of prescription opioids. His use continued to escalate. He then progressed to consuming hydromorphone and then heroin. Recently, he has progressed to smoking fentanyl. Now, what we often use for quantifying the amount is something called a point, and that's often what patients will use as well. So, for example, a point is 0.1 gram. So 6 points would be 0.6 grams. So Alex is using this amount. As he's finding it difficult to find other forms of opioids, so this is why he's using fentanyl. When he doesn't consume opioids, he experiences several withdrawal symptoms, including cravings, chills, muscle pains, runny nose, nausea, diarrhea, and irritability. He craves opioids daily. So these are all classic opioid withdrawal symptoms. Alex is in clinic because he would like to stop consuming illicit opioids. Due to his opioid use, he lost his job, lost his driver's license, and now is about to lose his apartment as he's using up his savings on fentanyl. His urine drug screen today, done in clinic, is positive for fentanyl. The physician uses the DSM-5 criteria and diagnoses Alex with a severe opioid use disorder. So what is buprenorphine? Like all forms of opioid agonist treatment, buprenorphine is a long-acting opioid. It's synthetic, meaning it's man-made, and as it's long-acting, it can control opioid withdrawal symptoms for over 24 hours. What's unique about it is that it's a partial agonist with high affinity, and we will see how these two properties have significant clinical consequences, both good and not so good. Why is buprenorphine considered first line? Well, it's as effective as methadone, which we'll talk about later, and has significantly less drug-drug interactions, significantly less risk of QT prolongation, reduced risk of respiratory depression, and reduced overall side effect profile. In addition, if when tapering from buprenorphine, it has less withdrawal symptoms compared to methadone. Now, in Canada, essentially all buprenorphine formulations indicated for the treatment of opioid use disorder are always combined with another drug called naloxone. This was done to reduce the potential for misuse because naloxone is an opioid antagonist, meaning that if buprenorphine naloxone happens to be abused, in a way crushed and injected or snorted nasally, the naloxone component will be absorbed and will cause unpleasant withdrawal symptoms. So it acts as a deterrent. But if the individual patient takes the medication as prescribed, which is sublingually, meaning under the tongue, the naloxone will have no effect because it has very poor bioavailability orally and sublingually. Hence, the active or therapeutic component of this combination drug is simply buprenorphine. Please note that naloxone, which is a rapid-acting antagonist that is also used to reverse opioid overdoses, is not the same as naltrexone, which is a longer-acting antagonist. This is usually used for alcohol use disorder as an anti-craving medicine. It tends not to be used for opioid use disorder in Canada. So the dosage forms for buprenorphine naloxone vary, and it depends on the manufacturers. Here you will see some of the formulations available. You can see that the first number denotes the dose of buprenorphine, which is really what we care about. And the second number indicates the naloxone component, and you can see they're all in a 4-to-1 ratio. As I mentioned before,